Thank you for being here today, attending our Emory Division of Hospital Medicine CPC. We have a very interesting case today, and we have multiple presenters, and we're going to start with giving the presentation from Eric Caliendo, who is going to introduce himself and describe the case, and that will be followed by consultant Dr. Rashida, Barrie, and we follow up with the expert, Dr. Shi and Dr. Weinberg. So I will give it for Eric Caliendo to start the presentation and introduce himself.
Okay, can everyone hear me? Very good.
Yes.
Yeah. Okay, awesome. I'm Eric Caliendo. I am a second-year resident, so don't adjust your TV sets. This is the hospital medicine CPC, and I am a resident, but Dr. Andy Massert, our assistant professor in the Division of Hospital Medicine, did submit this case and was chosen for this conference. I was her intern for the patient. She was gracious enough to allow me to present today. I want to thank her for the opportunity, but we have a lot to talk about, so let's get started. Let's start with our chief complaint, which was memory difficulties and trouble completing tasks. So this is a 73-year-old man. At baseline, the patient is in good physical and mental health with only mild fatigue and gradual memory issues attributed to old age. He was completely independent in activities of daily living, as well as management of a large cattle farm. So for the past 2 weeks preceding presentation, the patient had progressive difficulty with usual tasks. Initially, he forgot the names of folks in his life, which was uncharacteristic, and that progressed to difficulty with calculations and writing for work. Eventually, he could not perform simple multi-step tasks, such as getting into a car or putting on his clothing correctly. When prompted to separate these tasks into their component steps, he was usually able to carry them out. On review of systems, the patient had no other symptoms. Notably, he denied any headache, weakness, numbness, vision changes, confusion, fevers, chills, or weight loss. For his past medical history, the patient had non-alcoholic steatohepatitis progressing to cirrhosis that was diagnosed in 2019. He also had known small esophageal, gastric, and retroperitoneal varices. A recent MELD was 11. He had one HCC lesion diagnosed just over a year before presentation. It was confined to a single lobe. It was treated with 2 Y90 embolizations 7 months before presentation. He had no chemo or immunotherapy. He also had a basal cell carcinoma of the nose that was removed by Mohs surgery 3 years prior, and an unresected left ear squamous cell carcinoma. He had well-controlled hypertension on a single agent. So the patient was born and raised in Tennessee, where he currently lives with his wife at the time of presentation. He owns and operates a farm with livestock. He had past alcohol use occasional and none since he was diagnosed with liver disease. Never smoker, no history of IV drug use, and he was never incarcerated. His mother had congestive heart failure of unclear etiology, no strokes, and no significant cancer, a family cancer history. He took metoprolol succinate 25 daily and vitamin D. He had no known allergies. So when he came to the hospital, his vital signs were within normal limit. He was afebrile on room air. His physical exam was largely benign. No jaundice, no scleral icterus. Some pertinent positives that we did note was a firm, non-tender liver tip palpated just below the right costal margin, but his abdomen was otherwise benign, no distension, no fluid wave. He did have some trace bilateral pitting lower extremity edema up to the knee. Edema was non-painful, and it was common for him to have this minimal degree of lower extremity edema. Also noted was the small scaling whitish red patch on the left earlobe, unchanged. This was his known squamous cell unresected of the left ear. So we focused a lot on the mental status of this patient, as this one is his chief complaint of memory issues and difficulty completing tasks. So he was oriented to person, place, and situation, but he reported the year as 2002, and the actual year was 2022. He had mild deficits in calculation, word finding, writing, abstraction. He actually said the similarity between a bicycle and a train was that the bicycle is small. He also had deficits in attention. He could not spell the word world backwards, and he also had that difficulty in memory, both short and long term. He followed one-step commands, but was unable to reliably follow two-step commands. To round out the rest of his neurologic exam, he had fully intact cranial nerves. He had a normal strength exam to confrontation, but we elicited a right upper extremity pronator drift. He had no asterixis and no abnormal movements. Sensation was intact. He had brisk deep tendon reflexes throughout, right greater than left, with a positive right Hoffman sign. He did not have any clonus. His cerebellar and gait exams were normal. So we got, he had lab work in the ED. His admission chemistry is shown here. Normal electrolytes, he did not have an anion gap, and he had normal renal function. On CBC, there was mild normocytic anemia and thrombocytopenia that were similar to recent values. I included his baseline hemoglobin of 10 to 11 there. He had a slight indirect hyperbilirubinemia and a slightly elevated INR. These were similar to previous values, although a prior ammonia level was not available. His ammonia was slightly higher than the upper limit of normal for our lab, and his MELD was calculated to be 12. So I'm highlighting the lab abnormalities for you here. And naturally, with this change in his cognition, we wanted to ensure that there was no structural insults or bleeds. So we opted for a CT scan of the head. So I'm giving you a moment just to take a look before giving you the read. And as you can see here, there's two discrete regions of vasogenic edema. Here in the right parietal and in the left occipito-temporal lobes. There were no other intracranial abnormalities, no large territorial infarct or hemorrhage. We obtained an LP in anticipation of more advanced CSF analysis for the odd appearance and location of these lesions. And the immediate results from the LP were within normal limits. And we'll let our discussant determine what other studies she would like to obtain from this lumbar puncture sample. We also sent some other serum studies. Notable ones are listed here. We wanted to determine if there was presence of a systemic infection, kind of gauge the degree of inflammation, and the presence of common conditions linked to altered cognition, as well as some other chronic diseases. All of these studies were normal or negative, as you can see here. We did obtain an MRI to better characterize the lesions that were found on CT. So again, one moment just to orient you here. Pictured are three different sequences of MRI showing the left occipitotemporal lobe lesion. So the MRI showed three T2 hyperintense lesions in the bilateral parietal and left occipital lobes, centered in the white matter, and they spared the cortex. So these are in the same regions as the CT findings. There was some faint peripheral diffusion restriction on DWI scan and no contrast enhancement on the T1 post-contrast image. One of our experts, Dr. Weinberg in Neuroradiology, will dive a little deeper into these images after our hospital medicine discussant digests all this information for us. And speaking of, it is time to bring out Dr. Barrie to guide us through the case and build our differential diagnosis.
Thank you so much. Let me share my screen. All right, can we see well?
Yes.
Okay, perfect. All right, so I'm Rashida Barrie. I'm a hospitalist at Emory Decatur Hospital. I've been at Emory for about 4 years, and I'm very excited to dive into this very interesting case. I don't have any disclosures. All right, so encephalopathy or altered mental status is a very broad, like, umbrella term that encompasses a very vast differential diagnosis. And it's so important to be very systematic and very focused when trying to come up with a differential to figure out what's going on with our patients, both for this case and, you know, in our general practice. And it's often that we have to go, like, work our way back. It's like building a picture or like doing a puzzle. You're getting all the different pieces, you're putting it together, and you're trying to understand exactly how everything flows together and how and that will allow you to make the diagnosis in the end. All right, so how do you approach a patient? So as I was saying before, you have to be very systematic, establishing what the patient's baseline is. Often the patient's confused and can't really tell you what their baseline is, but speaking to family members, people who see them often, like caretakers, it's so important to know so that you have a comparison. You can say, okay, this is what differs from what the patient is normally able to do. And, you know, get more information from, you know, family members, including the family history. That might be relevant depending on what kind of case that you're dealing with. It's also important to review past medical records so that you know if there are any changes in, like, say, the electrolytes, you know, if there was an acute drop in the sodium or acute change in the renal function, you're able to make comparisons based on the labs that you would inevitably get when the patient comes in to be evaluated. So it's super important. And that includes reading the history from the primary care doctor and consultants that the patient may see. Our patient, you know, had a history of cancer. So, you know, figuring out what was the last note and what they discussed, if there were any changes. Obviously reviewing the labs, like I said before, if there are acute changes in the electrolytes, you need to know about that, and reviewing the radiology data from prior so you can make comparisons. Important, medicines can cause confusion. We have new medicines coming out on the market very frequently. It's important to ask about any medicine changes that happened recently, or new medicines that have been newly started. Also supplements, you know, we often forget to ask about supplements. People have access, you know, to get them from, you know, social media, Amazon, friends, and they can cause confusion in patients. So it's important to ask. And then performing a thorough physical exam, you know, most importantly, the neuro exam will be important, but, you know, just what the patient looks like, their hygiene, their skin, the cardiopulmonary exam, all of these are very important and can give clues to what might be going on with the patient. So going back to our patient, I highlighted some of the things that are kind of important in his case, his age, 73. So that eliminates certain differential diagnosis given his age. The acuity of it has been going on for 2 weeks. And his baseline is that he's good, right? Like, he's in good, generally good physical and mental health. He's only had mild fatigue and some, you know, age-specific memory loss. He's independent. He can take care of an entire farm. That's hard work. So, you know, he's able to maneuver pretty well given his age. And now he can't make the calculations that he needs for his the farm management, and he's having difficulty doing complex tasks. So I've listed some differential diagnosis under broad categories. This is not an exhaustive list. You know, there are so many things that can cause confusion. Neurologically, stroke, you know, seizures, tumors, hemorrhages. You know, his INR was slightly elevated. You want to make sure that you consider that he might have some bleeding. Metabolic causes, hyperglycemia, hypoglycemia. Medications, like I had mentioned before, antibiotics, steroids, particularly in elderly patients, can cause a lot of confusion. And then infectious causes, sepsis, due to bacteria, fungal infections, viral infections. Traumatic, if he had a fall, he works on a farm, you know, he could potentially have trauma as a result of taking care of his farm. And psychological, you can have new psych disorder. It's unlikely given his age, but it's possible. And with the age appropriate group, it could be possible. So back to our patient, he has NASH, which is complicated by hepatocellular carcinoma. He's been treated twice for that, most recently in the last 7 months. That can be important. However, he's not known to have any extra hepatic spread, and he's not received systemic chemo or immunotherapy for his cancer. Of note, he does have a history of basal cell carcinoma of the nose, which was treated with Mohs, and unresected squamous cell carcinoma, which was seen on physical exam when Dr. Caliendo was presenting earlier. Again, so this is my same slide with some of the differential diagnosis. I removed trauma and psych because it seems like that's based on the patient's presentation, that those are a lot less likely for this patient. So, and as I said, these are just examples under broad categories that we can consider for this patient. So in terms of his meds and history, he's on metoprolol. For varicella prophylaxis, he's also on vitamin D. Socially, he's from Tennessee, he was born and raised there, and he doesn't have any history of IV drug use, and his alcohol, since he's been diagnosed, he had stopped drinking alcohol and he only drank socially. On physical exam, he's oriented, but he gets the year wrong. He's not jaundiced. Like I said, it's important to take the patient in, notice skin changes. He doesn't have jaundice. He doesn't have asterixis. And he does have word finding and difficulty completing complex tasks. The liver is firm and it is palpated. That is noted. So that's a positive finding, which is not unexpected given that he has hepatocellular carcinoma and he has trace lower extremity edema on physical exam as well. A note about hepatic encephalopathy, it seems like that might, based on the case presentation, might not necessarily be what we're dealing with, but I thought it was important to highlight it because it just shows that encephalopathy can have multiple causes. You can have advanced liver disease and still have another reason to have encephalopathy. So we shouldn't just assume somebody with advanced liver disease confusion is only because of hepatic encephalopathy. We have to keep the differential diagnosis very broad. But basically, this is a reversible syndrome of an impaired brain function in a patient with advanced liver disease. And this liver disease can be anything, cirrhosis, cancer, and because of cirrhosis, because not only of alcohol, it could be NASH like our patient had. The symptoms are wide. It can range from subtle to coma. And often as healthcare, when we go down to the emergency room to evaluate patients, some of the symptoms might be subtle. And therefore it's important, like I said before, to talk to family members, to talk to caregivers. They're the ones who can spot subtle changes that happen in our patients. And as I said before, more severe cases, it's coma, the patient isn't able to, is completely obtunded and needs to be intubated. But on physical exam, you can see asterixis. There are other signs that you can see, and head CT can show marked cerebral edema. All right, so a differential diagnosis. So, I removed infectious just based on the presentation. Again, we're keeping it very broad. And these are just some examples under broad headings. There can be additional ones. We can think of more that we could put under these broad headings. So we'll see under metabolic, the labs will be very helpful to guide us to see what might be the cause of what's going on with him. So labs wasn't a whole lot of lab derangements, right? Like most of the testing was basically within normal limits or close to normal limits. He does have anemia. As we discussed before, it's mild, he's close to his baseline. His INR is a little bit elevated. He is thrombocytopenic, but he has been thrombocytopenic in the past. That is not a huge change for him. And his serum ammonia level is 76, which is a little bit elevated. And this slide is super busy, but we've seen it before with the previous presenter. I just wanted you to be able to see that basically the testing didn't point us definitively in one direction or the next. But we can say for example, certain metabolic causes are less likely. For example, like his sodium is within normal limits, so we can't say that that was the reason for it. So it has helped us eliminate a lot of metabolic causes for the patient's confusion. All right, a note about serum ammonia level. It's produced in the GI tract. It's not diagnostic. Before we talked about he didn't have a level that we could compare it to previously. That's important. It's important, moving forward, if he were ever to have an issue again, knowing what his baseline was previously is important. So it's not diagnostic. It doesn't make the diagnosis. It is helpful, but it is not diagnostic or prognostic. And one note, if you have a patient with advanced liver disease, you get an ammonia level, the level is within the normal range, then you may want to start thinking of other things going on causing the patient to be confused. So CSF analysis, some of the things that I would like to get for CSF analysis, opening pressure. That can be very helpful, guiding us to see what might be going on, glucose, protein, cell count with differential, gram stain and culture, oligoclonal bands, and viral and bacterial testing as well would be additional testing that I would like to get for this patient. And neurotesting, neuroimaging. Not all patients need an EEG. Sometimes it's helpful when the diagnosis is a little bit confusing and you want to eliminate subclinical seizures. I don't believe he had one, and it's not always necessary unless there's a strong suspicion for that. Head CT, MRI brain, which we saw for him, are very important testing in patients who are presenting with confusion. And I'm just showing again, there are two discrete areas of vasogenic edema, which was seen in the right parietal and the left parietal occipital lobe. And this is the brain MRI, which we saw previously. And the experts are going to break it down more for us. All right, so in summary, to summarize all that's going on with the patient, he's an elderly cattle farmer who's pretty functional, with some mild cognitive deficiencies at baseline, who has a history of hepatocellular carcinoma, which has been treated twice by radioembolism. He has basal cell carcinoma and squamous cell carcinoma. He had a 2-week history of being unable to complete tasks. On physical exam, he has a firm liver edge and mild pronator drift. CSF, all the findings so far in terms of lab work were not very diagnostic, didn't point us in a direction, but the CT head and MRI head had interesting findings that we will delve into further. So differential diagnosis, I think it's neurological. Again, we have to keep it very broad. This is not an exhaustive list, as I said before, but I do think that the findings on the CT scan and the MRI are probably what is going to give us the final diagnosis for the patient.
Great, thank you so much, Dr. LaBarrie. That is where we were when we were presented with all this information. We definitely needed help from other folks. So I'll bring in Dr. Weinberg now to kind of really dive into the MRI, which was an important, very important piece of our data.
Sure, thank you. I'm gonna try to share my screen here. I want to thank you for inviting me today, and it's a very interesting case. I'm going to pull up some of the imaging findings here, which have been briefly shown, but hopefully I will be able to show them to you in a little bit more detail here. What we're going to review is, so I have here the imaging from the CT of the head. This was the first study that the patient had when they came to Emory, although they had an outside MRI. So the timing of it is a little interesting. And this is going to scroll through for you here, so you can see in a little more detail, and then I'll go back. So you've seen kind of snapshots like of this as we've gone through, but what you can see is there's a couple of areas of abnormality. You see here, there's some edema. It's been pointed out that that's vasogenic edema. And when we think about vasogenic edema in radiology, we think about edema that's sparing the cortex. And so when you have edema or loss of gray white differentiation that goes all the way to the cortex, then you think more about stroke. But this is not typical for stroke. And then you have another couple of areas over here. And so you're kind of thinking about, you have some sort of cause of edema. That's not stroke. It could be a number of things. It could be encephalitis. It could be metastatic disease. Although the tumors that this patient have had rarely go to the brain. Like, we rarely see basal cell skin cancers in the brain. We rarely see hepatocellular carcinoma going to the brain. Just to show you a little bit more, you can see like just a couple of screen captures from this, a few scattered areas. Those white matter abnormalities are kind of highlighted there. And this just kind of summarizes what they've seen. Now, anytime you've seen this, like, all of these patients are going to go on to have MRI. Like, the purpose of the head CT is to screen for hemorrhage, sort of big strokes, and decide MRI is ultimately going to be what helps us kind of hone that differential a little bit. This is a little bit backwards, as I said, because the patient had already had an MRI. This is just a movie of the flare from that outside MRI. Where you can kind of see those abnormalities. Again, you can see on the MRI, they're actually a little bit more numerous than you could even appreciate on the CT. So you've got kind of this one over here in the left posterior temporal lobe. You've got kind of this right inferior parietal one. You've got another kind of smaller one over here, kind of in the temporal stem there, kind of along the Sylvian fissure, and then another one up here. So multiple, again, white matter lesions. And here you can also see that same concept where it's sparing the cortex there. So you're not necessarily thinking that these are infarcts. Now, this is just some of the different sequences that are through these areas. This top left is going to be diffusion weighted imaging. You can see this kind of rim of sort of brightness on diffusion. This is that left posterior temporal lesion. Again, flare right here is kind of sparing the cortex. And then it's pretty dark. This is T1. You can see it's dark. There's kind of loss of the normal myelin signal there. It's dark, and this is post-contrast, again, showing, as Eric pointed out, like very little or no contrast enhancement. Here you can just see through a couple of the other lesions, you see kind of similar features, faintly bright on diffusion, low T1, bright on flare, no enhancement really there. And that was kind of characteristic of all of these white matter lesions. Here you can just see those two that are a little bit more vertical. Again, these sort of bands of diffusion hyperintensity there. Now, I'm going to point out an unusual feature that you kind of see in this case. Between gyri, there are white matter connections that connect adjacent gyri. So they kind of go immediately between gyri. There aren't that many diseases that sort of systematically affect those fibers, and those are called U fibers. And when you see that, it's demyelinating disease is one of the things that it brings to mind. And what you kind of see is sort of these U-shaped lesions that are sort of along these U fibers, and that does make you think about demyelinating disease. And I'm using the term demyelinating disease to be broad, because that includes, say, acute demyelinating disease like ADEM, longstanding MS, or transverse myelitis, or other like demyelinating processes like PML. The summary, like on this MRI, was, like I said, we have multiple scattered white matter abnormalities. They spare the cortex, so probably not thinking about stroke. They do have some reduced diffusion, which can be either cell necrosis or can be tightly packed cellular material. Now, there's no enhancement, and that kind of almost all metastatic disease enhances, almost all lymphoma enhances. So you're probably not thinking about that. It kind of seems similar to the CT. Now, when you see this kind of appearance on your differential, like the imaging differential overlaps a lot with what was already presented. You're kind of thinking about, is this an infectious encephalitis? Or, I mean, what we're dealing with is an encephalitis. The question is sort of what's causing it. Is it infection? There's a number of viruses. Bacterial encephalitis can cause this. There are a number of non-infectious causes of encephalitis, like lupus, posterior reversible encephalopathy, those kinds of things. I already brought up the notion that it might be demyelinating disease. A couple of things that like these imaging features sort of help you exclude. Metabolic disease like would be unusual. The kind of things you're thinking about are like uremia, perhaps, or hyperammonemia. These are almost always symmetric bilaterally, and in this case, it's asymmetric, so it would be somewhat unusual. Tumor, it's very rare to have non-enhancing tumor, like a primary brain tumor in multiple locations like this, so it's kind of less likely. And as I've already pointed out, like metastatic disease is kind of less likely as well because of the lack of enhancement there, and the fact that his primary tumors are not common to get brain metastases. So to help you kind of sort through this a little bit, I've selected a few similar cases with similar findings. This is a case of infectious encephalitis. What you can see is the temporal lobes are T2 or flare hyperintense here. Again, you see kind of this subcortical, almost like U fiber involvement. This was a case of Eastern equine encephalitis. Here you can see the leptomeninges are also abnormal. So this patient had meningitis from Eastern equine virus. Here you see a case of inflammatory encephalitis. This is a patient who was having acute cerebritis exacerbation from lupus. And you can see kind of similar findings, patchy white matter abnormalities, kind of subcortical involvement, maybe a posterior distribution. This is a case of tumefactive demyelination. So this was a single lesion. You can see again, sparing of the cortex, subcortical involvement, kind of wrapping around the bottom of a gyrus there. Here you have a little bit of enhancement, but it's not a dominant feature. This rim of abnormal diffusion looks kind of similar to our case here. And I kind of also brought up PML. You can see it has some overlap in the features as well. Again, you see U-shaped lesions involving the U fibers between gyri. This is a PML in a patient who had advanced HIV. You kind of see the multiplicity of these lesions, the fact that they're kind of asymmetric there. The patient did go on to get MR spectroscopy. I'm kind of an MR spectroscopy expert, and I will tell you from that perspective, it is often not that useful, but I will point out some of the features of it, which are interesting here. When you do MR spectroscopy, what we can do is we can essentially place a cube or a voxel over a region that you would like to interrogate. And what you get is a spectroscopic a spectrum from that region that shows you what the metabolic composition of that region is like. What I have on the left here is a voxel that's been placed over a normal region of the brain. And this is a normal spectrum. And you kind of see three sort of peaks here that are sort of the key peaks. Choline is a marker of membrane turnover. When you have proliferative processes, this tends to go up. Creatine is a marker of energy metabolism and tends to stay the same in many processes. And NAA is a marker of normal neurons. So when you have something replacing normal neurons, it goes down. Here you can see the voxel on the abnormal side. And what has happened is NAA is low and choline is high. So what you're dealing with is something that's, you have mild sort of proliferation there. This can be inflammatory processes like infection or MS, but you have loss of normal neurons. This is additional peak here, which is lactate, which means you have some necrosis there, which can be seen with tumors. It can also be seen with processes like anything that causes cell death, infarction, demyelination. And so if you see lymphoma or brain tumors, usually their choline is much higher. So usually would be up here. And this made them believe that it was probably not a tumor. We were kind of leaning away from that direction anyway. This just highlights some of those peaks that I've pointed out here. I'll just show you quickly, like the patient did have 3 MRs, like 1 at the outside hospital and 2 at Emory. I will show you that there was kind of very little evolution over time. So the lesions were pretty stable. They perhaps did get a little bit more mass, like a little bit more expansile at the end, but kind of stayed the same over a 2-3 week period. To summarize the imaging for you, though, we have this multifocal, predominantly white matter process, not really enhancement. We have spectroscopy that suggests kind of a mildly proliferative and necrotic process, doesn't favor tumor, and kind of this U fiber involvement is seen in only a couple of processes. So that kind of makes you think about that. But your overall differential is infectious, non-infectious encephalitis, demyelinating disease. Those are kind of the main things you'd think about.
Thank you so much, Dr. Weinberg. That was really enlightening. And I know Neuroradiology worked closely with Neurology, and I will pass it over to our neurology colleague, Dr. Shi, who's very helpful in helping with this patient. So I'll let her take it away.
Great. Hello, everybody. My name is Helen Shi. I'm one of the neurologists at UH. Thank you so much for this opportunity to share this case with you and to participate in this grand rounds. Really appreciate everybody's input so far, and discussion has been great. So I'll go ahead and get started with our differential diagnosis, building up on what Dr. Barrie had shared with us, and also Dr. Weinberg, that this is a really interesting case. So this elderly man who comes with these multifocal, non-enhancing, very T2 hyperintense lesions in both sides of the brain that were asymmetric, and with his background of having cirrhosis, NASH cirrhosis with hepatocellular carcinoma, and no obvious immunosuppression to our knowledge. We felt that the differential diagnosis included posterior reversible encephalopathy syndrome, as Dr. Weinberg had highlighted, that there are these areas of vasogenic edema that we're clearly seeing on MRI. Most of them are posteriorly oriented, and it seemed like his risk factors of having liver failure, or the cirrhosis itself is a risk factor for posterior reversible encephalopathy syndrome. Also, he was mildly hypertensive. His only home medication was metoprolol, but his blood pressures were only mildly elevated, like systolics of 140s while he was in the hospital at times. He did not seem to have other significant risk factors for posterior reversible encephalopathy syndrome, such as renal dysfunction or calcineurin inhibitor use or steroid use. And so it was something considered radiographically, and based on the fact that he has liver disease, but didn't have additional risk factors for PRES. Demyelinating conditions were really at the top of our list for the differential, as Dr. Weinberg had highlighted, that the involvement of the U fibers on the MRI, these multifocal white matter lesions, so areas where there are myelin that appear to be affected and destroyed. And so our differential included demyelinating conditions that are in like the primary CNS demyelinating disorders spectrum. So that would be like ADEM, acute demyelinating encephalomyelitis, which can be seen in older people. It can be non-enhancing, but typically ADEM occurs as like a post-infectious inflammatory reaction, such as if somebody had some type of infection several weeks prior, they could develop ADEM afterwards. Certainly it's much more common in children and young people, but that was a consideration for him, although he and his family denied any prior infectious symptoms or illnesses. Neuromyelitis optica and myelin oligodendrocyte glycoprotein associated disorders, so NMO and MOGAD, are two very prominent CNS demyelinating conditions. But with that, we would expect there to be enhancement in these, what we felt were probably acute lesions that went with the time course of him having progressive symptoms for the last couple of weeks. Similarly, for multiple sclerosis, we would have expected to see enhancement. It would be unusual in his age group to develop new multiple sclerosis. Hepatic encephalopathy was something else that we considered. Just hepatic encephalopathy with hyperammonemia could cause vasogenic edema in the brain. His ammonia was only mildly elevated. He never had a history of hepatic encephalopathy. And like Dr. Weinberg had said, it would be unusual to have asymmetric lesions from a metabolic disturbance like hyperammonemia. Paraneoplastic syndromes are always considered when we see unusual MRI findings. And with paraneoplastic syndromes, this would be, a paraneoplastic encephalitis. They can occur with hepatocellular carcinoma, although typically they, as with all paraneoplastic syndromes, they occur earlier on in the course of that person's malignancy, perhaps before the malignancy is even detected, or in the very early stages, as opposed to somebody who has established hepatocellular carcinoma. who has already gotten treatment and is considered to be stable. Progressive multifocal leukoencephalopathy was another diagnosis that we initially did not consider significantly because of his lack of clear immunosuppression. We asked the family in so many different ways, and if he could have any type of treatment in the past that could cause him to have immunosuppression, any medications that he could have taken, or diagnoses, rheumatologic conditions for which he may have been on immunosuppressive therapies. And he did not have any of those previously. His HIV testing was negative. But the imaging, if this were a patient with HIV, then at the very top of our differential would be PML, because of the fact that he's having these multifocal leukoencephalopathy, like multifocal white matter changes on the brain that have no enhancement. That is very characteristic of PML. And then neoplasm was much lower on the differential for all the reasons that Dr. Weinberg had already shared, the lack of enhancement in particular, and also the spectroscopy findings. So the hospital course for this patient, and I'll just go by kind of systematically, this is how I think about our patients, is kind of going through the differential and also sharing the hospital course for each of the conditions that we considered. So for the possibility that he could have had posterior reversible encephalopathy syndrome, we had recommended controlling his mild hypertension, repleting his electrolytes. There wasn't anything particularly modifiable about his liver disease that we could do that would be impactful. For the possibility that he could have had a CNS demyelinating condition of the autoimmune inflammatory type, we did send oligoclonal bands in the spinal fluid, as Dr. Barrie had requested. We sent NMO in the serum and MOG antibody in the serum as well, which both resulted negative. And we did give him empiric IV solumedrol 1 gram per day for 5 days for the possibility that he could have had ADEM or some other type of autoimmune encephalitis. And he had no improvement. This was something that was kind of debated at the time of, well, maybe he has PRESS, steroids, this dose of IV solumedrol could worsen his PRESS. And this was shared with the family as well, of these, with the information that we have in our, what we are considering on the differential. We really want to help him get better. We felt that PRESS was much less likely. Maybe he could get better with steroids if he did have a steroid responsive condition. And so they were agreeable with trying the steroids, and we monitored him closely, and he had no decline while on steroids, but also no improvement. For the possibility that this could be neoplastic or perineoplastic, we did send the serum and CSF autoimmune encephalopathy panels. We also performed a malignant screen with a CT chest, abdomen, pelvis, and that had shown some very small pulmonary nodules, and it showed his cirrhotic liver with the previously treated liver lesions. And we had sent CSF cytology and flow cytometry that were negative. For the possibility that he could have hepatic encephalopathy that was for some reason causing asymmetric lesions on MRI, we did treat the hyperammonemia with lactulose, and did not seem like there was significant improvement in his condition either. And then with considering the possibility of the progressive multifocal leukoencephalopathy, the best way to diagnose that would be with sending JC virus PCR in the spinal fluid. Brain biopsy could also diagnose PML, but that's pretty drastic and not in our routine practice in trying to diagnose PML. And so repeating a spinal fluid, like repeating a lumbar puncture and sending the spinal fluid for JC virus PCR would have been ideal, but the family strongly did not want to repeat a lumbar puncture. And so instead, we did send a serum JC virus PCR, which I'll go into in a later slide about the utility of that. And so after he had gotten his steroids and he was monitored in the hospital, was getting his lactulose, his blood pressure was controlled, it was felt that he could continue further workup outpatient. And so he was discharged from the hospital, although he did not have significant improvement. And perhaps to no surprise, he did re-present to the hospital less than a week later because there was further decline. As soon after he returned back to the hospital, the JC virus PCR serum test had resulted positive. And so this was some information that we shared with the family, and he was agreeable, the family was agreeable to repeating the lumbar puncture. And so the spinal fluid was, again, non-inflammatory, and the CSF JC virus PCR was positive. And so he fulfilled diagnostic criteria for progressive multifocal leukoencephalopathy, which I'll spend the remainder of the presentation discussing PML. So PML, progressive multifocal leukoencephalopathy, which I have highlighted over here on the left. These are images that I pulled from Radiopedia. This is a typical appearance of PML, which looks very similar to what our patient's MRI looked like. JC virus granule cell neuronopathy is another form of JC virus reactivation that affects the granule cells that are in the cerebellum and extending into the brainstem. And so this is another way that JC virus could show up in the central nervous system. And so JC virus reactivation causes severe CNS demyelination, and it's due to reactivation of JC virus that infects astrocytes and oligodendrocytes, as well as the granule cells that are in the cerebellum. And so JC virus is a polyomavirus. It's very commonly encountered in the environment. Many of us are exposed to JC virus, and we may have JC virus antibodies. Our PCR, if we're not having JC virus reactivation, our PCR in the serum and CSF would be undetectable or negative. But JC virus is very commonly encountered in the environment. It's spread by person-to-person contact or via contaminated food or water. Generally, it's swallowed. And then once it's swallowed, it's spread hematogenously and harbored in lymphoid tissues as well as the kidneys. And this is a site that JC virus may be indolent and just present in a person's body. Many of us may have this in our bodies, and it's generally suppressed by cellular immune response. And so if our cellular immune response is working properly, then it will keep the JC virus in check and will not reactivate and will not cause problems for the person. However, when a person is immunosuppressed, for example, has HIV/AIDS or is taking immunotherapy, disease-modifying therapy, for example, for multiple sclerosis, which as a neurologist we encounter a lot. One of our medications called natalizumab, also called Tysabri, has a very high chance of causing JC virus reactivation. And so that's something we monitor our patients very closely for. Also with lymphopenia of any kind or any cause, this could cause JC virus to reactivate. And then specifically that JC virus reactivation can infect the central nervous system in the astrocytes and oligodendrocytes, granule cells, as I mentioned earlier. And then that can lead to disease in the central nervous system, of which PML is one form. And so what was interesting about this patient's case is that he, at least on the surface, in our encounters with him, examining him, looking at his laboratory studies, talking with his family, he did not seem to have any overt immunosuppression. And so PML was not at the top of our differential, even though, in our discussions about his case, we frequently brought up, oh, what could he have PML? What about that possibility? And we kind of didn't take it seriously until we saw that he wasn't improving with the steroids. And it made us look into his case more in terms of, what literature is there about PML in patients with minimal or occult immunosuppression. And so people have published on this. This is an article from 2010 where they discussed 38 cases of PML in patients without HIV and without clear immunosuppression. And interestingly, 7 of those patients had cirrhosis, and our patient has cirrhosis. It seemed like cirrhosis is a potential risk factor for PML. In this article, they also shared that among 22 patients without a diagnosis, cirrhosis or renal failure, pregnancy dermatomyositis, among those 22 patients, 5 did have CD4 T cell lymphopenia, and 1 patient had borderline lymphopenia. There's a theory that in cirrhotic patients, the gamma globulinemia and portal hypotension could cause splenic sequestration of leukocytes, which could effectively make them leukopenic, lymphopenic. And so that could be a risk for developing PML. As part of the study, they shared that 71% of patients died and the median was 8 months. And so from this article and reading other papers, it seems like sending a CD4 count, even in a patient without HIV, but a patient with PML without overt immunosuppression, it would be reasonable to send a CD4 count that could reveal perhaps this patient could have relative lymphopenia or true lymphopenia. It was not sent for our patient, unfortunately, as the family had decided to transition to hospice. And so we did not feel that would be useful for his care. To note, our patient did, as we looked back, really in retrospect, looking back through his chart, did see that several months earlier, he did have mild lymphopenia of 780 per microliter, although did not have lymphopenia at the time of presentation. And what's relevant to this, and something that was brought up in later discussion, was that 25% of patients who received the type of treatment that he had for his hepatocellular carcinoma, that the yttrium-90 radioembolization could cause lymphocyte depletion and lymphopenia, and that they have sustained lymphopenia after that treatment. And so perhaps this, in combination with his cirrhosis, were his risk factors for developing PML. And so a word about the diagnosis of PML, as I mentioned earlier, that JC virus PCR DNA detection in the spinal fluid or via brain biopsy showing JC virus proteins on immunohistochemistry, in addition to the clinical and radiographic findings, make the diagnosis of PML. And these are the imaging findings that we discussed earlier, which are that there's T2 hyperintensity, T1 hypointensity in the subcortical white matter, could have a demyelinating front on DWI imaging, as Dr. Weinberg had shown us, and that there's usually no mass effect and usually no enhancement. Something that I wanted to share, as I mentioned earlier, about sending the serum JC virus PCR, is that a study had been performed between Indiana University and Italy. This was published a couple years ago. Had shared that in patients who had PML, JC virus, serum JC virus PCR was detected in 48% of patients. And so it's something that, prior to this case, I had not really known the utility of sending a serum JC virus PCR. I've only ever sent it previously in the CSF, but in this patient, because the family very adamantly declined doing a repeat lumbar puncture and there was no additional spinal fluid that could be sent to the lab, we did decide to send the serum JC virus PCR. And with this article that we had found, it seemed like there could potentially be utility. If it's positive, then it could indicate that he could have PML and could guide management. And so positivity in the serum could be seen in patients with PML. Interestingly, 3% of controls, so patients without PML, did have a positive JC virus PCR. And so there are false positives. And so the take-home message is you could consider sending a serum JC virus PCR when CSF is not available, or if the CSF JC virus PCR is negative. That was also something discussed in this article, that a diagnosis of PML could still be made. And that was more common in patients with HIV, that they may have a negative CSF JC virus PCR, but a positive serum JC virus PCR. And so I'll spend the last few minutes talking about PML treatment. And so the main goal is to restore the cellular immune response. And so for HIV patients, that would be to start antiretrovirals. For our patients on immunosuppressive medications, for example, natalizumab in a multiple sclerosis patient, the treatment would be to stop that medication. For other patients, for example, with hematologic malignancies, organ transplantation, idiopathic immune deficits, the prognosis is worse, mainly because there's not something that is clear that we could do to try to treat the PML in terms of, starting antiretrovirals or stopping immunosuppressive therapies. But we could try to invigorate the immune system. This includes immune checkpoint inhibitors. So, pembrolizumab, for example, or other immunotherapies that we use in treating malignancy have been tried in treatment of PML. Also, polyomavirus specific allogeneic T cell transplantation has also been tried. It is important to monitor for immune reconstitution inflammatory syndrome, which I won't get into too much in detail, but basically if somebody has neurological worsening while trying to treat their PML, definitely repeat an MRI, look for contrast enhancement, which would be a hallmark of iris, and typically we treat this with IV steroids. And so this is a table that I just wanted to share from a 2021 article in Annals of Neurology that had shared 37 cases of PML patients treated with immune checkpoint inhibitors, 28 cases treated with that T cell transfer treatment that I mentioned earlier, and the associated conditions that they had, the treatments that they used, and then their outcomes, which generally seemed like about a third of patients had a favorable outcome, a third of patients were stable, and then a third worsened. And so not excellent treatments that we have available today for patients without clear immunodeficiencies or, these potential treatments that we have. But this is definitely an area of research that's ongoing. And so in summary, I want to share that PML is a demyelinating condition caused by reactivation of JC virus in immunocompromised people, and rarely, not obviously, immunocompromised people. The imaging findings that we mentioned earlier of T2 hyperintensity without enhancement, our diagnosis being made via JC virus PCR in the CSF, and to consider sending it in the serum if we cannot get the CSF, and then the treatments as I mentioned. That is all. Thank you so much for your time. These are my references.
Awesome. Thank you very much, everybody, for great presentation. Obviously, this is a complicated case, and unfortunately, the patient did not make it. But we will open for any questions if anybody has. A couple minutes we still have. Since there is no treatment for JC virus, would the steroid sometimes make it worse, or is there any studies looking into steroid usage with these patients?
That's a great question. I did not see information specifically about steroid use in PML. My assumption is that it may make things worse. and so I wonder if that was part of why he appeared to worsen, and his MRI also appeared to worsen slightly. I'm just imagining that it, steroids will further suppress the immune response. And what we really want to do in treating PML is to invigorate the immune response. And so, immune checkpoint inhibitors is something that we had entertained slightly when we made the diagnosis of PML. I curbsided one of our infectious disease colleagues to ask, who treats PML in this hospital, like in this situation? Is it like infectious disease? Do they have expertise in this? Or is it like us from neurology? And he had said that he has used immune checkpoint inhibitors in the past, and he would be happy to consult on the patient and work with us. But the family had chosen to have him enter hospice, which is very reasonable considering that he was listed for liver transplant for his cirrhosis, and he was at that time taken off the transplant list because of the PML diagnosis.
Well, we are on time. Thank you very much for everybody being here with us today. Great presentation from the team, and we're looking forward for the next Emory Division Hospital Medicine CPC to be done in the fall. Thanks, everybody.
Thank you.
Thank you.